Good evening, everyone. Namaskar, Sasrikal, Adab. Welcome back to yet another episode of SAFE, which is presented by our ANEI Patient Safety Fellows. Association of Nurse Executives India, I am sure that most of you are aware. Association of Nurse Executives India, or known as ANEI, is an association, a group of nurse leaders who have come together to make this association. It was started in 2017, and now we are growing and we have got many activities that Annie does, and this is one of the mainstay activity. And Annie has started the Annie Patient Safety Fellowship Program, and we take applications from any members. Then they go through an interview, they go through a proper review, and we induct them into the ANEI Patient Safety Fellowship Program. Just give me a second. Let me just officially start the session by doing our ANEI Patient Safety Anthem as well. Just give me a second. Can you all see the slide?
Yes, ma'am.
Yes,
Yeah?
ma'am.
Okay. So SAFE stands for
Yeah, we
Safety
can
and
see.
Awareness for Excellence. So please, I request all of you to please stand for the anthem.
சார்ஜர் இருக்கு சார்ஜர் சார்ஜர்ல தான் கொடுத்துருந்தேன்
We are the voice, the hands that care,
இருக்கீங்கல்ல எப்பயும் போல
guardians of hope, always there, with wisdom and courage. We stand tall, answering the call, serving all. In every moment, through joy and strife, we lead with purpose, we honor life, building the future with knowledge and grace, transforming healthcare in every space. Passion to action, our guiding light. For every life, we fight the fight, upholding safety with hearts so true. We are ANEI, proud in all we do. Together we rise, united we lead, planting the seeds for a brighter tomorrow. Together we rise, united we lead, planting the seeds for a brighter tomorrow. ANEI, nurses make the difference to humanity, shaping the future with strength and unity. Passion to action, our guiding proud in all we do.
Thank you, everyone. So you may please be seated. So this safe sessions are brought to you by ANEI Patient Safety Fellows. And this fellowship program is being run in collaboration with Patient Safety Movement Foundation, USA. ANEI's vision and commitment is to have zero harm. All the avoidable harms should be completely avoided. And Patient Safety Movement Foundation also, their tagline is first do no harm, zero by 2030. So all this endeavor, anything and everything Annie does actually leads to patient safety. All roads in healthcare, patient safety. So we did have a calendar when we started 2025. We are actually in the 11th month, and October we had to postpone. So in November month there will be two sessions, and in December will be the last one, and then we will come up with yet another calendar. And today we have Anuradha Batta. She will be talking about innovative approaches to pain management. She's a ANEI Patient Safety Fellow 23-26. The 2 years fellowship program. The first year, the fellows spend time learning and doing improvement projects. And the second year, they will be actually mentoring the previous cohort. So it takes 2 years for the fellowship to complete. So a very warm welcome to this session. And the next session will be presented by Anuradha Patro. She will be talking about nurses' well-being and patient safety. We hope to see you all again in November in large numbers. Thank you so much for being here, and a very, very warm welcome. And the more number we see here, I'm very happy that people are concerned. And today we are going to talk about pain management. Pain management is a pain. I know that. I had been a CNO, so I know that management itself is a pain. It's not only a pain for the patient, it is also a pain for leaders and CNOs, because we don't get our head around managing the pain of our patients very effectively. Many a times we fail, we make mistakes. But today, Anuradha is here to actually tell us different modalities that are currently in place, and you will also be learning about advances. What are the newer methods of pain management for patients? So over to you, Anuradha, and a very, very warm welcome. And
Thank you, ma'am.
we will take the questions towards the end. As you, if you have any questions, you can put them in a chat box, and we will take it once Anuradha will finish the presentation. And meanwhile, a humble request to all of you to keep your audio and video muted. Allow Anuradha to speak, peacefully. And thank you. So Nagarani, you are now unmuted. So please make sure that you are muted. So I will also be making myself muted and not on video. So over to you, Anuradha. I'll just check your presentation. Please share.
Yes, ma'am. Thank you, ma'am. Good evening, everyone. I would like to thank ANIE and Ma'am Tangam for giving this opportunity once again to present this topic, that is transforming the way we care for patients. Innovative approaches to pain management. Pain is the one of the most common distress experience faced by the patients, and as healthcare professionals, it's our duty to find more effective, compassionate, and evidence-based way to manage it. In this session, we will explore how to see the new technologies, how to learn about it. And before starting my topic, I would like to start with a small story which has happened. I was just reading through some of the magazines about the pain-related medication, how it has been misused. A 22 years old male nurse was working in the emergency department, and he was complaining about the back pain. Then he started taking the tramadol injection, and he felt very comfortable, free from the pain, and he has started continuing it, and he was became addicted for the drug. Thereafter, the management got to know that he has been misusing these drugs. So he became completely depressed. Without drugs, he was unable to stay and continue his life. Management got to know and his license was cancelled. Likewise, there was a nurse also working in the ICUs where she was misusing the injection fentanyl. So what she was doing is that she was just taking herself for pain and replacing with the normal saline in the syringe. So she was trying to hide this again from the management. During the checking, it was got to know that she is misusing it, and management caught her and seized her license of the nursing for the complete life. So, moral of these two stories, what I would like to just mention is that the drugs to be used in a proper manner and the monitoring supervision is very important. So, let me share my PPT slides. Give me a minute, please. One minute.
You can put it on the slideshow, Anuradha. It's visible.
Yes, ma'am. Yes, ma'am. So, innovative approaches to pain management is the topic. The objectives of this session to understand the latest innovations in pain management, to explore non-pharmacological and technological approach, to identify nurses' role in applying these methods. We all know the definition of the pain, that pain is an unpleasant sensor and emotional experience associated with the actual and potential tissue damage, or describes it in the terms of damage. As per the International Association for the Pain Study of Pain, the pain management is considered such as an important part of the care, that the American Pain Society coined the phrase as the pain is the fifth vital sign. So we always see that vitals, but some of the nurses, we don't understand the importance of pain, but it is the part of the vital signs and we should not miss this. The types of pain, we have this acute and chronic. The acute, if you look at the pain, is it will start and stay for few seconds and up to the weeks and months. The chronic pain persists for 3 months and more. By mechanism, nociceptive and neuropathic, nociplastic. These are the categories of the pain types we can see, and this nociceptive pain arises usually in the trauma, and neuropathic pain, we can see this kind of pains in the diabetic patients and hepatic and neurologia. And nociplastic pain, these are the things we can see in the fibromyalgia. As we all know that most of the hospitals, the common pain assessment tools are these, and we can score while doing the assessment according to the scales, the total score of each scale we have mentioned here: mild, moderate and severe. Here it comes very important for the nursing role. It's the responsibility of our nurses to see the patient and give the proper safety during the pain assessment, documenting, monitoring. Pain assessment, as I mentioned, these are the tools what we are using. Numerical scale, Wong-Baker, FLAC for children, and PANID. So, and reassessment is very important once we assess the pain. And it is very important just not to document, but it is need to be interacted with the patient and check their expressions. How are they exactly explaining the pain properly or not? As we administer the medication, it is also not to miss out about the reassessment. Many times what happened, due to the busy schedule, some of the nurses, we fail to do the reassessment and they forget because of their busy schedule, due to the manpower shortage, due to the rounds, due to the other activities, they miss to do the reassessment. But it is very important to go back and check the patient whether pain has been reduced or not. From 0 to 10, what is the pain score initially was mentioned and what is been reduced to. Holistic assessment, During the assessment, it is also need to be checked. Where is the pain actually? What is the intensity? What kind of patient pain is complaining to? How far patient is having, how long patient is suffering through pain? Is it triggering somewhere? And is it in the same place? These are the few questions if the nurses can make, the patient can able to explain very clearly. Considering emotional and cultural and spiritual aspect of pain is very important. Documentation, once we started assessing pain, and documentation is one of the evidence that the nurses it's need to be keep and document in the patient file. And we also see sometime it will miss. They say that did you check the patient, did you assess, did you reassess? Then they say that, oh ma'am, I forgot to document. So it is very important whether the documentation is manual or electronical, but it is must to be documented. And note both verbal non-verbal cues. Planning and implementation, pain relief, pharmacological care, non-pharmacological interventions, and innovative approaches. These are the things I'm going to talk in the upcoming slides. Monitoring and evaluation. Once the medication is given, monitoring is very important for the continuation observation and reassess the pain after the intervention. As mentioned, must the interventions to be documented and reassessed. Identifying the pain again after the interventions, and vital monitoring is very important during this period. We also see that patient feedback after the pain is reduced, they will be updating how is the pain, whether it is reduced or not. And clinical judgment, one of the most important tool to communicate promptly and while checking with the physicians. We need to be updated with them, communicated properly, how is the pain reduced or not, further what to be do, and how to document. Pain education, pain education in this medication need to be explained to the patient and family to be part of this drugs, because there are sometimes the patients will be misusing the drugs. They also need to be informed about the frequency, dose, route, and the side effects. And self-management, teaching relaxation techniques, breathing exercises, mindfulness. These are the few things we have to be informed to them. Encouraging for the journalizing digital tracking of the pain levels. Family involvement to be monitoring further for the proper instruction has been followed by the patient or not. The family to be involved in this. Communication and collaboration. This is again very important. It is not only the nurse's job, but in the hospital sector, the team coordination with the doctors, the physiotherapist, and pharmacist and psychologist also need to be part of the team to discuss with the patient about the pain. Communicating assessment findings, intervention outcome during the handover rounds, and ethical and safety responsibility. Patients should know the rights and responsibilities. The continuing education and research, it has to be part of the nurse, especially need to be part of this kind of continuing education and research to stay updated with their knowledge, and attending the workshop to know aware about the new tools and innovative devices about the pain management. The problem, the crisis of chronic pain and opioids. These are the staggering scale of the chronic pain. We see millions of people worldwide suffering with the pain. In India, if we see the patient who are diagnosed with the cancer, palliative care, most of the diagnosis that pain is part. Therefore, it is becoming the very problematic in the worldwide. The long-term management, according to the WHO guidelines 1986, this is the ladder which has been prepared. So here it is mentioned the stepwise for the mild pain, the scoring, and what are the drugs to be involved in the score 1 to be given. The step 2, mild and to moderate pain, what is the score system and what kind of drugs can be mixed and given. The step 3, for moderate pain, what are the group of drugs can be given in this step. Categories of innovative approaches. Now we look at these 5 categories, and pharmacological, advanced and non-opioids and personalized therapies, neuromodulation and neurostimulation, regenerative medicine and cellular therapy, alternative and integrative therapies, digital health and AI innovations. Now look at the one pharmacological and approaches to pain management. Drugs, novel agents, drug delivery system that is transdermal and intranasal, liposomal, and adjuvant medicines that is antidepressant and anticonvulsant drugs, multimodal analgesia and personalized medicines. This pharmacological approaches to pain management 1.1. I have just mentioned the details about the drugs, what kind of category drugs will be used in what kind of situation. For example, I will just mention about one. This is for the information. Most of the hospital, they have their own hospital setup protocol, what kind of category drugs to be used. This is just information sake I mentioned. According to the NMDA receptors, antagonist, these are the drugs being used to calm and overreact to the nerves that keep sending the pain signals. For example, ketamine and low dose dextromethorphan. This is used in the chronic pain and nerve pain, palliative pain. So like that, I have mentioned all the category of the drugs and which disease they use to. And how the new pharmacological advantages differ from the existing pain medicine. If you look at the traditional pain medicines, mostly block pain chemicals like prostaglandin, NSAIDs or act brain opioids receptors, and this is the traditional. In the new advanced pain management, we see that target specific pain pathways, and we have created nerve channels, receptors and pain molecules. These all been mentioned in the new advanced pain management. Often less effectiveness in nerve or cancer related pain, but here we say that highly effective in the neuro. And common issues, we see that there are side effects related stomach irritation, constipation, sedation, but we see in the new thing there are not much side effects. Followed by that, we also have mentioned a few more traditional pain medicines and new advanced pain medicines with the options and how it is, what is the mechanism, how it is affecting each thing we have mentioned here. I have mentioned here. And pharmacological advances innovative in the drug delivery system. This is and transdermal patches. We have seen many times that patches being used in the hospitals to release the medicine slowly through skin or mouth. Keeps this pain under the control for the longer with less stomach upset. There is no much side effects, but this has been used as sublingual films. It is like patches. Liposomal injection, if you see, this drug has been used for the post-op cases for the long lasting to reduce the pain. And intranasal, most of the times we see the sprays which are being used, intranasal spray and buccal roots, and this is work fast through the nose, mouth, and used for the sudden breakthrough pain. PCA, patient controlled analgesia, allow the patient to control their own pain relief by pressing the bottom to deliver the preset dose and pain medication. These are usually iPods through the programmable infusion pumps they use like infusions. And multimodal analgesia, balanced approach to relieve the pain. What is actually multimodal analgesia means using two or more types of pain medicines or techniques together to get the better relief of pain. Fewer side effects will be there, but this can be combined and give. For example, I can just mention one drug is paracetamol and tramadol. This is non-ipods plus opioids. Each medicine acts on the different pathways, so their effects add up while side effects do not. So no single medicine can relieve all pain. Combining the right medicine safely is the art of multimodal analgesia. The new horizon of the pain management is what it is and how it is works. The personalized pain medicine means choosing the pain for treatment based on the each person unique body, genes and pain type, not using the same drugs for every patient. How it works is that it uses genetic testing to see how fast or how slow person peaks down the medicine and studies pain sensitivity, lifestyle and medical condition and aims to give the maximum relief with maximum side effects. Every patient pain is unique, so their pain medicine should be unique too. Sorry. So personalized future pain medicines followed this approach example how it works. Followed by that slide, I have added few more points here. I'm just mentioned to go through. So here comes again the nurse's role. These are the category of drugs, how the nurses has to play their role, and practical example. One or two points I'll be discussing here. Drug novel agents understand the new drug's purpose, dose, side effects, and monitor the patient pain levels and the response. Report any unusual reactions promptly. The practical example is that after striking the ketamine infusion, monitoring for the confusion or BP changes, reports to the doctor. So, drug delivery system, educating the patient how to use the patches, films, and check the skin irritations or rash under the patch. So, ensure the correct disposal of patches are used. If patient using the fentanyl patch, check placement site and timing of the change. So all the time we just apply, but we never check back what is going on the patient while applying patches, or once the infusion is started, we never check. We miss to do that whether it is started flowing or not. Is there any blockage or it is stopped in going this medication? So these are the some of the main important things to check before and after and in between the medication started. The second one is this neuromodulation. The neuromodulation, neurostimulation definitions and mechanisms I mentioned. The use of electrical and chemical and physical stimulation to alter nervous system activity in targeted fashion. Neuromodulation means changing the way nerves send signals to your body, especially signal that causes pain. And you can think of it as a turning the nervous system rather than shutting off or cutting off out of it. Instead of using medications to block the pain in the brain or reduce the inflammation, neuromodulation uses tiny electrical impulses or the other energy forms to talk directly to the nerves that carry the pain messages. 2.2, how it works. Pain signals travels from the body through the spinal cord to the brain. We just mentioned when those signals are too strong to continue like the chronic pain, the brain keeps hearing the pain when the injury has healed. Neuromodulation sends a mild electrical pulses to the certain nerves are a part of the spinal cord. These pulses changes how the nerves behave, and they may block, weaken or distract the pain messages before they reaches to the brain. The result is that the person feels less pain or more comfortable tingling instead of constant pain. Neuromodulation and neurostimulation. 2.3 common types are the SCS, that is spinal cord stimulation, peripheral nerve stimulation, PNS, and non-invasive devices. So if you look at the spinal cord stimulation, near the spinal cord, electrodes near the spinal cord send pulses to the interrupt pain signals. Peripheral nerves will act as the small electrodes that target nerves and near the painful areas. Non-invasive devices, tools like TENS pads, and you place on the skin or magnetic stimulation of the brain, do it without surgery. 2.4, why it's important. He helps the people who pain, does improve with the medicine or surgery, and can be personalized and adjust for each patient, reduce the need for long-term painkillers, especially opioids, and usually reversible if it doesn't help. The device can be turned off or removed. Neuromodulation 2.5, nurse's role. Again, here comes the nurse's role, pre-procedure role and intra-procedure support, post-procedure monitoring, outcome evaluation, and interdisciplinary collaborations. Most of the surgical patients we see in our hospitals providing details patient education about the procedure, expectations and device operations, and assessing for the psychological readiness and rule out the contraindications. So this will be the pre-procedure role. Intra-procedure support, maintain the sterile field, assisting during the implantation, tridal stimulation, and monitoring the vitals. Post-procedure monitoring will be the vital monitorings and check for the infections and lead for the migrations, device failures, and educating on the wound care and device uses, charging calibration, and safety. Outcome evaluation is that assess the pain reduction, quality of life, and functional improvement. Interdisciplinary team is that again the team of the doctors and the nurses and neurologist will be assessing for the pain specialist and the device techniques. They have to be checked for the optimal use and follow up. Now we look at for the three regenerative medicine and cellular therapy. What is regenerative medicine and cellular therapy? Regenerative medicine, it is about helping the body to heal itself by replacing the cells, tissues or organ that are damaged or not working properly. It doesn't just manage symptoms like painkillers do. It aims to restore the original functions of the damaged part of the body. A simple analogy is that think of your body as a garden. When the soil, your tissues, it is damaged. Regenerative medicine adds new seeds and fertilizes growth factors. So the garden can be grow back healthy again instead of just trimming the weeds symptoms. Regenerative medicine, how works? When you get injured, the body tries to repair the damage naturally using the special heal cells. But sometimes we see chronic pain or nerve injury. This can be seen in the natural repair system. This helps to reduce the inflammation, rebuild the tissues, restore the functions, leading to the less and pain and better movement. Regenerative medicine 3.2 main types of cellular therapies I've just mentioned here, how it is functions. Regenerative medicine 3.3 advantages of the regenerative cellular therapy: target the root cause of the damage, not just pain, may delay or even avoid surgeries in some cases, use your your body's resource usually, and potential to repair nerves, joints, and soft tissues, chronic pain conditions, can work together with neuromodulation and rehabilitations for better outcomes. Regenerative medicine 3.4, again the nurse's role comes here. Ethical and informed consent. It is also be part of the nurses will be just part of the consent. However, the consultant will be taking the consent, procedure and assistance, observation and follow-up, patient support, education and research. Alternative and integrative therapies. Next, fourth one. What are the alternative and integrative therapies? These are the alternative integrative therapies, a treatment that combine traditional and medical care with natural or holistic approaches to help and manage the pain and improve overall well-being. Difference between the alternative and integrative. Alternative therapy used instead of conventional medical treatment, for example, using the herbal and instead of the pain medication. Integrative therapy used along with the standard medical treatment or combining the best of both worlds. For example, using physiotherapy plus acupuncture plus mindfulness and prescribed medication as well. So these are the integrative pain therapies. Acupuncture, everybody been heard about the acupuncture. Very thin needles are inserted at the specific points on the body. This helps to stimulate the nerves and release the natural painkillers like endorphins, and used for the headaches, arthritis, and back pain and nerve pain. Massage therapy, this is also nowadays it is becoming very famous. Improving this by massaging therapy, this will help to improve the blood flow, relax the muscles, and lowers the stress. Can reduce the chronic tensions and pain caused by the tight muscles or injuries. Yoga and Tai Chi and mindfulness meditations, herbal and nutritional therapies, and chiropractic and care. These are the some of the common types of alternative integrative pain therapies mentioned here. And alternative, again for the here comes the nurse's role: holistic care, evidence-based practices, and patient empowerment, interprofessional coordination, and documentation and evaluation. Here comes the digital AI innovations. Digital health and AI innovations. Digital health means using the technology to improve the healthcare, from mobiles, apps, and wearable devices to telemedicine and electronic health records. We have seen this most of the time. Telemedicine was used during the COVID times because the people were feared to travel, so they were using this. This technology got very popular during the COVID system, and AI, artificial intelligence, nowadays adding the ability for the computers analyzing the data, learning patterns, and make predictions, helping doctors for the smarter, faster, and more personalized decisions. So through this, the doctors, the team can be taken very quick decisions. So this all together is going to help the patients and prevent, to monitor and take quick decisions. How do the digital innovations help in pain management? Uh, these are the very interesting things which I found. Virtual reality, VR therapy, and digital therapeutic wearables, mobile apps, and AI pain diaries, AI based predictives. In the if you look at VR therapies, immense patients in a different environment, acting as a powerful distractions and helping to the rewire brain's perception of pain through the neuroplasticity. Studies have shown that we are to be effective and reducing the pain during the medical procedures and for managing the chronic pain. In the digital therapeutic wearables, pain management, apps like biofeedbacks, devices, wearable sensors, empower patients to track their symptoms, engaging in the guided therapies, and regain the control over their bodies. Mobile apps, AI pain diaries, patient can log in the pain intensity, triggers, and medication use in app like pain scales, managing my pain. AI algorithms identify the patterns, suggest interventions, alert clinicians for the worsening of pain. The nurse's role here teach patients how to record accurately and interpret the pattern for the better adherence. Now, most of the hospital we see, we have the team of nurses who just work for the pain management in the hospital. The team, the doctors, the nurses, they go around the hospital and they check for the pain and assessing for the pain documentation. As a team, they are working. So these are the few things in the digital innovation it will come. And 5.3, the nurse's role again, digital pain assessment, telehealth virtual care, AI driven decision support, data privacy, and professional development. So digital pain assessment, use wearable sensors and apps capturing the real-time pain data, interpret the patterns of the early interventions, and telehealth virtual care, conduct virtual consultations, guide patients in self-monitoring, and provide follow-ups. AI-driven decisions, collaborate with the data scientists and clinicians to integrate the AI recommendations safely into the care plans. Validate the algorithmic suggestion with the clinical judgment. It is continuation with the same as I already mentioned in the previous slides. And data privacy ethics, this is again one of the very confidentially that patient data to be kept confidentially, and informed consents to be secured, stored properly, the data sharing, and cybersecurity compliance. Professional development, engaging in the training and digital literacy and imaging the technologies, contributing the designing and nurse-friendly interferences and pain management dashboards. Uh, these are the, maybe we were thinking that which hospitals this has been using, but when I was searching about the content for this PPT, I was reading so many articles. So I got to know that many hospitals like government hospitals in Delhi and Apollo hospitals in Chennai and Josalok hospitals, Manipal hospitals, many hospitals in India has been using this all the innovative approaches for the pain management. These are my references for the pain management. Um, thank you so much. Thank you, Ma'am Tangam, for giving this opportunity once again to present this topic.
Thank you, Anuradha. Now we open this for discussion. You can stop sharing, Anuradha.
Yes, ma'am.
So we have got a lot of senior leaders here, and we heard Anuradha mentioning that some innovative approaches of pain management is being practiced in our top corporate hospitals. So I would like to hear from the participants. If you are, can you stop sharing, Anuradha, please? So you can come on the video and share what is the new thing that you are, uh, deploying in your setup for pain management of your patients. We would love to hear practical things. So most of the slides that we heard are all theoretical. So now we need to hear some practical aspect of it, because technology is going to be invading every aspect of our care, including the pain management. So, yes, please unmute yourself, come on the video, and please share before I start calling out names. If you come yourself, it is good.
Namaste,
Hi,
ma'am.
Rekha. Namaste.
Hello, ma'am. Ma'am, the new thing I have heard here, that is pain AD,
Yes, okay.
and I'm going to implement. Actually, I'm going to read in detail on this, and I'm going to implement it at my place after discussion with my quality team.
Yeah, Pain 80 is something that I also learned new today. So I just read it up and I shared information. So that is what you learned from today's session. That's really cool. So do you use anything apart from the standard scales that we used to use when I was in 2012 when I left the hospital? So inside the hospital, we were pretty much using the standard, pain scores and giving the regular medicines following the WHO ladder. And then there used to be few, one or two special pain management centers where people used to go for chronic pain. So I would like to hear from the people who are actually still practicing in hospitals. What is your experience? How is the pain being managed for your patients? Hello, nurses. Can unmute yourself and speak up. Leaders, my ANEI Patient Safety Fellows working in hospital. You can unmute and say, no, we don't have anything new. We are still practicing the same thing.
Ma'am, Abdul this side. I was trying to unmute because I'm connected over mobile, so I was trying
Okay.
to, swap
Okay.
screens. Okay, ma'am, I come from basically an oncology background, and I work for an oncology hospital. For us, pain is a very important aspect, and though probably I could say before I could join, we had little of pain scales, but despite having all those things repeatedly, we were trying to get lots of non-conformities, because oncology being a area where patients pain perceptions are more different and organ specific. So as an part of in quality and as a part of a requirement for NABH, we came in with an idea of creating a patient centric pain nursing care plan, so which has a complete a combination of everything, where we try to have an initial assessment, and then also along with initial assessment there is also periodic reassessment, post surgery and breakthrough pain. Such categories have been given. Along with that, organ specific pain characteristics and the experience of that is also been given. So what happens is the nurses try to use a standardized scale. Probably say a patient is conscience oriented and able to verbalize pain, then we use VAS, which visual analog scale. A patient in ICU, we use a tool called CPOT, Critical Care Pain Observation Tool. This was again, I had to refer lots of things, and this was again the tool, I would say, innovated, invented, or created, however the word we use, by a nurse basically. I forgot the nurse's name, somewhere in abroad. So we adopted that particular tool called CPOT, Critical Care Pain Observation Tool. So again, the scores of all these pain scales are rated of 10. But in CPOT, what happens is the total score falls into 8, because there isn't two option for us to choose. One is a patient on ventilator, and a patient is able to vocalize on tube, without tube. So there is an option for us to choose. So it is a total score of 8 where we try to rate the pain score. Apart from this, the regular thing for pediatric, we use FLAC and the other things. So what we have done is uh, administration of a tool and asking the the pain, the scoring is the challenge for us. Most of our nurse, what they do is they show this particular pain scale, they ask, sir, isme number kya hai aapka? What is the number? So the explanation of the pain or the experience, how we are relating with this particular number, is actually not done by a nurse properly. So we took little more of extra work of training them, teaching them, training. And for this, I actually went during my masters. After my masters, I did my fellowship also in pain and palliative care, and advanced fellowship, to understand how this particular pain and concept is actually built in. As nurses, we are not been trained, so I took this fellowship through Indian Association of Palliative Care, Calicut, India. And with that particular knowledge, I was able to, kind of bring this pain care plan, whole shape. So this is what we are trying to use now. And we are also having a phone call system for a patients who are actually going back home, because we put the patients more onto chemotherapy. Nowadays we started even having kind of a home administered chemotherapy with the help of the isomeric pumps, the Baxter pumps, what we get. So we send the patient to home loaded with chemotherapy, and then the nurse, our clinical nurse specialist or nurse navigators, they try to call a patient and ask for. So what we actually use as a tool is we are using something called verbal descriptor scale. That is VDS, we call it as verbal descriptor scale. So what here, the categories, if I'm not wrong, it has something like no pain, mild pain, moderate, severe, very severe, and worst pain possible. So how do we ask, or how do we? This is kind of a subjective questions what the navigators try to collect, and what they ask is like to compare it with their hospital stay, what they had. If at all they're saying worst pain, the pain which they didn't experience in the hospital, and where they didn't get an IV medication, or they didn't get in morphine, or they didn't get in fentanyl patches or something like that. So that's how it is subjectively done. But probably again, we need lots of work on home care, pain management, or pain collection. But as of now, this is what at HCG we are trying to do.
Oh, that is fantastic information, Abdul. I mean, Seaport is again something new for me. So I'm getting an idea. Maybe we should do, special sessions on different tools, because in my experience of being in nursing for so many years, I totally agree with you that many a times the pain scales are there for them to verbalize themselves. They usually are not administered. So I will give you a couple of stories. When one of the things during when a patient comes for a surgery, let's say patient is coming for a surgery. So if you read more about pain management, even in the WHO also, it is about having the conversation of pain management before the patient even goes to surgery. So I would like to know that how many of us include pain management as a pre-op teaching. I know it's not happening because when when I myself in my own hospital when I got operated where I had been championing for this, no, there the excuse is ma'am knows about it, but it's no. My sister underwent hysterectomy, my niece underwent knee surgery. Nobody told what is that expected. When you have pain, this is how we are going to communicate, what scale that we are going to use. So tomorrow when you come after surgery, this is the scale, this is how we are trying to understand what is your pain, because pain is patient's pain. So sometimes nurses decide that this pain is mild, not necessarily it is mild for the patient. So the numbers 1 to 10 is something for patients, it's very, very simple. Just we have to tell, okay, 0 or 1 means hardly any pain. 10 is the maximum pain that you have. So when a patient says 7 and 8, sometimes nurses used to say, इतना हो नहीं सकता क्योंकि आपको दवाई दी है. Is that a correct response?
Yes, ma'am. Most time, the nurses used to tell the same thing, and they used to record, document heart to heart. The score is 2 or 3. Even though there is a point in our NABH aspect also, the pain assessment and pain reassessment. So there is a very difficult to get the responses from the nurses for the reassessment. That means their pain score is always less than 4. What is actually the reality of in our hospital scenarios?
So I'm not surprised that it's still not happening. We did a project when I was in Fortis for patients who are with knee replacement. So what we did that we told that our knee replacement patients will never go beyond a certain number. So what we did, we asked the surgeon, "Ki, what is the pain level that you expect all your patients to be?" So he said, anything 4 and below is okay. It's manageable. We can't expect any patient to be have saying, "Ki, I am zero pain." No, they will still have some pain, but it is managed and under control. The one thing that we introduced was that when the patient comes for surgery, we educated the patient how do we talk to each other about the pain management, and then we also used to ask them, what is your pain threshold? That means what is the level at which you need a medication. And I'm very sure Swarnalata's headache when she takes Panadol and my pain score when I take Panadol will be different. So, just for example, I will ask Swarnalata, at what number will you take a Panadol? Swarnalata,
Ma'am, it can be, I can say it is 5.
okay. And Abdul, what number you will take a Panadol?
Um, Probably 6. I because I have little a good pain, kind of holding ability.
Okay,
That's
so
how I
probably
felt. Yeah.
I am the best. I will not take Panadol till it is about 7 and 8. I will wait till the time it's really not hurting me. I will not. I will try to distract myself and do many other things. So imagine in a very simple question like three people, three of us told very different numbers. So why should we over medicate anyone? So this is all to make pain management personalized to the patient, right? How can we personalize unless and until we know what is this patient? And many times, nurses tend to say that, patients are illiterate, so they don't know how to count. So then they have the Wong-Baker scale, right? The faces. It's very interesting. One day I asked a nurse that you use this Wong-Baker because they have to tick which scale did they use for that patient. When you document, it's very important what scale they have used. So they use the Wong-Baker. So when we do audit, we ask the nurse, okay, use this scale, okay. So I said, how did you put this number? She wrote a number and she wrote some moderate or something. So I said, how did you do this? How did you mark this number? So she said, I held this picture and I looked at the patient. I matched the expression. Is that correct? Hello,
Yes,
ladies and
ma'am.
gentlemen. Is
No,
that
ma'am.
No,
correct?
No,
no,
no, ma'am.
ma'am.
That is
No.
Yes.
no,
So all of you are saying
no,
no.
ma'am. No.
Exactly. But sometimes this is what the nurses understand. So it is very important when we train our nurses, give them scenarios, give them the tools, and let them demonstrate to you that how do you assess. I have lots of stories. I'll tell you one more story. When I was in Fortis, when I was the group head, I used to travel to different hospitals. So I was in, I think I was in Chennai or Bangalore, I don't remember exactly. So pain management was one of the part of our nursing care bundle audit. So I used to personally check those aspects of the audits to make sure that the level of care in all our hospitals are similar. So I was in the ICU. Okay, I was on rounds in the ICU. Then I saw this very elderly lady. I can see that she's very uncomfortable. She's looking very uncomfortable and she's moving forward. So I asked the nurse who is assigned that, I think she seems to be in pain. What is her pain score? So my answer was that, Madam, she's not educated. So I said, even non educated patients can be told how to express the pain. I said, let me try. You come with me. So I went to the patient. Yeah, now I remember. It was in Chennai because I spoke in Tamil. So I asked the patient, Namaskar. I told her, Vanakkam. Then I asked her, இது எவ்வளோ இருக்கு? I showed my fingers and I said, எவ்வளோ இருக்கு? Then she had a smile, stupid, you're asking me how many? She said, 10. I said, very good. I said, thank you. Then I said, வலிவு கொஞ்சம் இருந்தா கொஞ்சம், கொஞ்சம். ஜாஸ்தி இருந்தா எல்லாமே ஓப்பன் பண்ணுங்க. This is my broken Tamila. Those who understand, you understand.
It's
So
actually
she looked at,
fantastic.
so she looked at her 10 fingers and she then decided to show this. So I told the nurse, this is all it takes. So I think it is also time that, the young nurses must see how the pain assessment should be done, because we tend to give a lot of gyan, lot of tools, so visual analog scale, numerical scale. So what I used to this lady was simple numerical scale, correct? No faces, nothing. Faces can be to those, even if they don't know, you show the face and say, this smiling face is no pain. This is the maximum. Please put your finger. That's how we are supposed to use the home baker. And all the, the pain scale for dementia, for patients who are on ventilator, they do have an aspect of observation. Now, just now I shared the dementia and the seaport. All of them talk about observing the patient for, seaport talks about observing the patient for 1 full minute before you write your number. So pain assessment is not going to be just like that, right? So, Ujjwala is telling it's not correct to assume pain is lesser than what they are saying. Exactly. We are nobody to decide how much is the pain of the patient. So I think there's so much that can be done. And at least I have not come across, major projects around proper management of pain. So please enlighten me, all the people who are sitting here. Have you ventured into, proper pain management, apart from Abdul, who talked about onco patients, because they need really special care, because if they are left in pain, I don't think anybody will forgive us forever. So I want to hear from others. So have you explored possibility of, taking pain management as a quality improvement project? Or have you done? I would like to hear from the participants in case you have done. Otherwise, we learn a lot, but unless they get applied to patients, it does not make any sense. Mary, you're unmuted. You want to say something? Please go ahead.
Ma'am, actually, the pain management, it is a really a very good the fifth vital signs. We should take very carefully. But the fact is that it is not happening in the field. So now coming to the thinking of putting the pain management nurse specialty, then pain come up, but the pain nurse are going to be recruited, all those in the plan, but so far it is not done. But again, we are stressing nurses to learn about the pain score and what is the importance of the assessment of the pain and reassessment after giving the analgesic. That is happening. Apart from that, nothing much in the field so far in
Thank
my
you, Mary,
unit.
for thank you, Mary, for that feedback. See, you
Yes.
cannot make too many pain management nurses. See, pain
Yes.
specialists can be there to supervise the pain management dedicatedly. It can make a difference. But I think most important is that when we train nurses, let's stop doing this PPTs and all this stuff, just use the simulation methodologies, create scenarios, give them the different scales. You should have it on print material and say, okay, this is the patient, this is the case study. Or I can be a patient, I can say, okay, I am this many years old, I just had surgery yesterday. Can be anything. Ask them to do the pain assessment. Do something like a role play. Let them talk to the patient. It takes a little bit of patience from educators. And also, it is very important on the spot teaching by the seniors. We somehow tend to repeat the same story again and again, that our nurses are no, because whatever Mary is telling is no different from what I had experienced. So only thing what I learned was that we have to have role models. We have to have people who will show them how to go about, managing the pain. And also sometimes managing the pain is just, you don't assess the patient. The basic, everybody knows PQRST. All of us have learned about PQRST abbreviation when you assess a pain. So I'll tell you a very funny story. Patient had, what was that? Inguinal hernia repair, male patient. Okay. He came back from the OT probably in the afternoon. So I am getting a call little late in the evening by the surgeon. Okay. So the story goes like this. Patient came back from OT. Patient came and he said, I'm having pain. So patient was given prescribed pain medication. After a couple of hours, the patient again complained of pain. The nurse told, I already gave you injection. Patient is saying, sister, dard ho raha hai. So the nurse calls the doctor. The doctor, resident, he says, so, okay, give him this. Okay. That pain medication also given. And after maybe another 1.5 hour, the patient again complains of pain. And then doctor and nurse, they both are wondering now, what are we supposed to do? That's the time the consultant comes. What do you think the consultant did?
Placebo.
No.
Remove the bed sheet and saw whether where is the pain exactly, and would have found that there was a bladder distension probably.
Exactly. So when the consultant came, he just decided to open the sheet and see where exactly is he having pain. The nurse and the doctor just assumed the patient is having postoperative pain because it is in the inguinal area and the bladder when it gets instead it gives discomfort and it will put pressure on the incision area also. So the consultant was calling me to tell me this. Look at this. So I used a little weapon. Though I said I totally agree, my nurse is at fault. But sir, I think you need to also talk to the doctor. Even he did not bother to examine the patient. So that does not reduce the incompetency of my nurse. We all learn when patient has got pain, we not only ask what is the scale, we should know where exactly is the patient. So it was so funny that when we trained all our nurses so much on pain and pain and pain, so all my nurses started asking pain score to patients who don't have any pain also. So they will ask a patient with pyrexia of unknown origin, 22-year-old boy also, आपको दर्द है? They are supposed to ask the patient has pain. So the patient started thinking, दर्द है, पूछा है तो कुछ तो बोलना पड़ेगा. फिर सोच के बोला, हाँ, थोड़ा सिर में दर्द है. Then the entire assessment starts. So it can be on the extreme, but I think we have enough patients in our hospital where we literally can do a bit more on the basic level of, pain management. I want to tell one more story. This is about fentanyl patch. This happened with my mother. Somebody asked the fentanyl patch here in the chat box, so I want to tell the story. So she was on paracetamol, she was on tramadol, and she was also given a fentanyl patch because she had D7 compressed fracture. And she's pretty old. She was 85 at that time. So we were, and doctor told ki, ma'am, don't wait to see how much is her pain. She'll have pain, so keep her pain free. Just give her the medication. So I had given all that. So one day, in her sleep, I used to sleep with her only. So she started telling that, your papa is talking to me. And his photo is there. Huh? I thought maybe she's becoming senti. I said, okay, what did papa tell? So she said, he's telling like this. Okay. And next day, this is happening on day. And then I'm not thinking more about it. I'm just thinking she's upset. Next day, she started telling why this water is flowing from this ceiling. It's all, all wet, green water is coming down. I said, Mummy, what is wrong with you? There is nothing there. Then I put her back to bed and I started thinking, why is she talking so irrelevant? She was not like that. Okay. Then I started going through all her medications. What medication could be giving her this confusion? Then I realized maybe it is the fentanyl. I forgot that she had a fentanyl patch. So I removed the patch. I called the doctor and he said, "Ki ma'am, just remove it, clean the area, and just wait for few hours." That was really, I mean, everybody else was thinking, she's just, in her element and, she's saying something. But it's very important when we are giving pain medication to different patients. Each patient will have a different, reaction. For me, you give me one pethidine injection today, I will be sleeping for 48 hours. I am like that. So I always used to tell when I had surgery, I'll tell the doctors, I'll take pethidine only if I have unbearable pain. Otherwise, I will not. Because then the doctors used to come for rounds and go, and I will never know who came and who went. I used to complain. So we know all these things. It's very important to train our nurses with stories and by simulation scenarios. Do you agree?
Yes, very true.
I think a takeaway from for all of us should be that we should get into training our bedside nurses which sounds relevant to them. It's important to show the path rather than have slides and keep telling them lot of theories. It does not work. Too many theories here, nothing happens to the patient. What is the use? Right. So, patient safety fellows, this is a food for thought. So, we have to see that what is it that we can do, even virtually, to showcase how to train nurses. Okay, the most common. The modalities, when they come, they will come, we will learn whether it is TENS or whether it is AI or any digital solutions. Many of the advanced pain management will be with pain specialist. So, anybody else wants to share anything before we wrap up? Thanks, Anuradha, for setting all this discussion, and I really hope that this discussions at least led and put some and I mean shed some light on how we should be approaching pain management in our hospital. We should know everything. We should know whatever is available. It's good to know, but it's
Yes.
very important. Come back to the basics and see: are my patients looked after well? Are their patients well controlled? So when you are auditing your nursing care, pain management should be definitely one part of it. It took a lot of effort to put these things in place in Fortis because we used to have patient interviews. So we used to go to patients and say, "Okay, how are you? How are things? Are you explained about the pain score by the nurse?" And they'll have to say yes or no. Then we'll say, "How much is your pain now?" So they'll tell. If they have learned, they will tell, "This is my number." Then we will go and check the file. Is it the same number? I remember when I was in Fortis Mohali, we were doing this audit, and the Punjabi patient post surgery. So I asked him, "What's your pain?" So he told me it's 4, and in the file it was written 7. So I'm asking the nurse, "Why did you write 7?" Then the patient said, "Madam, that 7 was before I got the medicine. After taking medicine, I'm 4." Don't you think that you will be happy as a nurse leader that your nurses are doing fantastic job?
Yes.
Definitely, ma'am.
So, patient facing audits are very powerful. Very, very powerful. You want to shift the patient experience, start talking to patients. Find out from them how they are getting taught, how they are being cared of. And if they say it's happening, you have to trust them. It's happening. So, with that last thought, I'm going to wrap up and thanks Anuradha for
Thank you,
this
mom.
session. And next one, we shift to nurses' well-being. Okay. So that is also very important. So let's see what comes up. And all the ANEI patient safety fellows who are here, please think about it and let me know if you have any bright ideas how we are going to train nurses better in pain assessment and pain management. Yes. Thank you everyone for
Yes,
being
ma'am.
around
Thank
and
you,
see
mom.
you again
Thank
in
you, ma'am.
November with yet another safe. All right.
Yes.
Okay, ma'am. Thank
Thank
you
you,
so
ma'am.
much.
Thank you, Anuradha, for setting that particular,
Thank you. Thank
lovely
you so
subject.
much.
Thank you.
Thank
to
you. Thank you,
everyone who
Abdul.
joined the discussion. Thank you. Thank you, everyone.
Thank you, everyone. Thank you, mom.
Thank you.
Thank you.
Thank you, ma'am.
Tabak hai.
Good night, ma'am. Bye-bye.